What do you say, Murli?
Yeah. Good evening. It's my pleasure to invite all my friends across the country. Today is an important day in the sense a very special topic we are going to discuss will be delivered by one of the eminent cardiologists of India. And more interestingly, this particular program, in fact, I have to register my appreciation to my colleagues, Dr. Bhupati and Dr. Puneetham, for doing this wonderful session we have been doing for the last several weeks. And they have invited their teacher, our teacher, Dr. Kothari, and I feel proud to be in this. Particularly, is going to be moderated by two other eminent cardiologists of South. One is my teacher, Dr. Jacob Jose. I joined DM at Vellore when Professor SK and Dr. Jacob Jose were the senior most faculty. Dr. Jose held my hand and taught many things in cardiology, both clinical, invasive, non-invasive echo. So I'd like to register my gratitude to Jacob Jose sir. And we have Dr. Raghavan sir, one of the eminent cardiologists from Frontier Lifeline, who had a long stint in Middle East also, extensively interested in academic work and a lot of good publication research and special interest in congenital heart disease work. So today is luminaries of cardiology have come together to deliver this lecture and the deliberations. With this short introduction, it's my pleasure. I take the pride to invite my teacher, Dr. Jacob Jose, to take over the proceeding and start the session. Thank you, sir. Jose,
it's indeed a pleasure to be with this program. I am thankful to SRMC for giving this wonderful opportunity of taking part in this talk. I thank Dr. Murali and the entire team. SRMC is so special to me because Dr. Thanikachalam was my examiner, and it was many times I had come to Ramachandra as examinership, and it is a pleasure to be in this program. I take this opportunity to welcome you all, especially Dr. Kothari, who is going to talk on pulmonary hypertension. I had known Dr. Kothari from a long time. After completing his DM cardiology, he came to Vellore when I was a student, and thereafter he worked. Every class he took was unique, excellent teacher, you cannot compare. His analytical approach, you will believe, you have to listen to. Then he left CMC, went to SRIHER, and of course he went back to his hometown called Ames. Dr. Kothari, it's a pleasure, and I invite you on behalf of Ramachandra as well as the entire people who are listening to you. And we are waiting to listen to you from pulmonary arterial hypertension. Dr. Kothari. May I request Dr. Murali to introduce Dr. Raghavan?
Yes, sir. I have introduced, sir. Raghavan, sir, would you like to add any words before we start the proceeding? We would like to listen from you before we start the lecture.
Yes, thank you very much. I really appreciate you calling me to this program, and you have got the right speaker for a very important topic like pulmonary arterial hypertension. All cardiologists have been aware of hypertension in the systemic circulation. In the last few decades, people have started realizing that the lesser circulation may not be so lesser after all. Pulmonary hypertension in the lesser circulation is equally important in congenital and acquired heart disease. And Dr. Kothari is going to take us down that topic in a step-by-step fashion. He is a very eloquent speaker. He got a touch of humor in anything he says. But none of you should be carried away by his apparent light-hearted talk. His very humorous way of talking hides a great depth of knowledge, and we're going to share a little bit of that depth of knowledge today. Dr. Kothari, it's a pleasure to be on the panel when you're talking, and I'm going to learn a lot from your talk. I look forward to it.
Can I start sharing the screen?
Yes, sir.
Good evening, all. It's my real pleasure to be there with you today for more than many reasons, actually. As you heard, Dr. Jose and Dr. Subramaniam are my great old friends. And I've learned so much from Dr. Subramaniam and Dr. Jose. And it's really almost a deja vu for me, seeing them and seeing Bhupati and Preetham. Let me tell you one thing, friends. If I ever get a cardiac disease, I would like to be treated by Preetham and Bhupati. So I have to come to, I think, Chennai probably to do that. And that is their, I have seen them, that is their level of, treating patient care. So today I've been asked to talk about pulmonary arterial hypertension. Some of you might have seen this video when we had the same talk in CSI Delhi. So if that is so, then you need not repeat because most of it is going to be same. I don't intend to tell so many things. When Bhupati asked me to speak about it, I was slightly reticent because I do not believe in teaching for exam. For me, I think education, there is no end to education. I think you people make too much fuss about exam. Exams will come and go. If you concentrate on learning, exam will look after itself. And some of you, if you fail, just remember, some of the most well-established interventionalists are those who failed once. So nothing much will be lost. So I don't think make too much about exam or passing, just concentrate on learning. So today we'll talk something about pulmonary hypertension. I do not know what Bhupati had in mind when he told me to talk step by step. I am generally not very systematic person in that sense. So what I decided, I thought I will talk with you whatever pulmonary hypertension I know. So I will be talking, some of it may be useful in exam, some of it may not be useful in exam. But all of you know pulmonary hypertension diagnosis is important and it is underdiagnosed. So many different diseases are causing pulmonary hypertension. More importantly, there are several factors which influence management of patients. I think thinking physiological is most important point in approaching pulmonary hypertension. We must think physiological in whatever is the patient. And in exam, you are supposed to give every patient what is PVH, what is pH. So obviously it's a great important topic. So what is normal PA pressure? Because I can't interact with you directly. So you think in your own mind, what is normal PA pressure? You think it is PA mean of 25 or 20? How much PA pressure can go on when we exercise? What is the normal pulmonary vascular resistance? A normal RV, how much force it can generate? What will happen if you occlude one PA branch? What happens, which are the vasoconstrictor vasodilators? Something like this. This is basically setting a stage for our understanding of the lesser circulation. And if we understand these answers, we are able to evaluate a patient properly. So normal pulmonary artery pressure, it turns out in thousands of patients, this has been tested. So normal pressure is only 14 millimeter. Normal PA pressure is only 14 millimeter. Lung is such a vascular compliant structure that raising PA pressure is a big deal normally. And no matter how much we exercise, we can probably increase the flow by 5 times, in athletes up to 10 times. But the PA pressure normally does not go above 30. It keeps on going a little more as we age. But by and large, PA pressure on exercise also does not go beyond 30. Normal PVRI. See, when we talk of PVRI in Wood units, 1, 2, 3, 4, 5, 6 looks small. But if you talk it in terms of dynes, so normal PVR is only 1 Wood unit, So even 2 Wood units become twice. So it's 80 dynes centimeter, dynes second centimeter to the power minus 5. And a normal RV can generate pressure up to 60 millimeter acutely. So if you have a patient in casualty with a pressure of 80, 90, most likely it's a chronic, acute on chronic situation. What happens if we acutely close a PA branch or we take out one lung for tuberculosis? PA pressure does not change. But what happens when a person is, a child is alive, he is born with one pulmonary artery only, single pulmonary artery, absent one pulmonary artery, there is a severe pH in them. So why this difference? One can think about this. Hypoxia, hypercarbia, acidosis are very potent vasoconstrictor. So the converse of it is one might recognize that how much hypoxia, hypercarbia, acidosis is allowed. There are several situations where we do permissive hypercarbia, especially in single ventricle management, etc. So it is said that PCO2 should not go above 70 and pH should not go above 7.2 because up to 70 PCO2 and pH of 7.2 could be a permissive hypercarbia, which will increase the PA pressure somewhat. Beyond that, it may be counterproductive, acidosis and hypercarbia. Other way around is when we hyperventilate. Sometimes we hyperventilate to decrease PA pressure. And we tend to forget what is the biggest problem when we hyperventilate. So if the hyperventilation goes beyond a limit, cerebral vascular constriction happens. So when the PCO2 falls below 30, cerebral vasoconstriction is counterproductive. So we must be mindful of the fact that we should not dip the PCO2 below 30. We should not get the acidosis above 7.2, and PCO2 can be up to 70. Life is compatible with the PCO2 300 also, but these are the limits of permissive hypercarbia. So when is the pulmonary vascular resistance least? Is it in a collapsed lung or an emphysematous lung? What happens when the lung gets collapsed or when the lung becomes emphysematous? So either way, the pulmonary vascular resistance rises. So lungs are most comfortable at the normal residual volume. So therefore, both will raise pulmonary vascular resistance. And we should be thinking about these things to make a clinical judgment. And most important point in approach to pulmonary hypertension is this graph. You know, we see patient day in, day out. For years, a patient with pulmonary hypertension remains well. As long as the heart is able to pump blood into the lung have a lot of capacity. So lung doesn't kill the patient. The killing thing in pulmonary hypertension is the heart. So therefore, as long as the RV functions are fine or RV is able to handle, therefore the pulmonary artery hypertension should be treated by cardiologist. It's a lung and heart disease, but as long as heart is able to pump the stroke volume, life can go on. When the heart starts failing, then the PA pressure can also drop. So you could have a patient where PA pressure is lesser than what it was before, just as previously it was suprasystemic and now it becomes subsystemic, but it is because RV has failed. Normally, in most of the diseases causing PAH, PVR continues to increase with time. And I think it's a good idea to think what is the cause of increasing PVR. Like the patient had a previously PA pressure of 40, 50 mean, and you see after 2, 3, 4 years, it becomes 60, 70. In almost all the diseases, PVR goes on increasing. And that is the reason for worsening of the diseases. And how does that happen? Whatever is the primary problem keeps on occluding more and more vessels. So PVR, as long as the PVR stays stable and RV is able to handle, the disease is not a big problem. There is some bit of dyspnea only. So these are the kind of thinking we should have. And once the RV functions start failing, the patient becomes more and more symptomatic, goes into heart failure, etc. Now, when you have a patient in the exam, he can be at any one point in this graph. So let us see, how do you think about the PA pressure? And I think most of you will be aware by now that now the PA pressure mean has been changed from 25 to 20. The pulmonary hypertension is said to be present when the PA mean is about 20. Now, when the guidelines said 20, we say 20. Previously, guidelines said 25, we said 25. But I think we should ask ourselves why this change has occurred. So as I told you, mean pressure was found to be 14 and 2 standard deviation is 3. So it is 6. So normal PA pressure actually goes only up to 20. So in the 6th conference, World Conference, in their wisdom, they thought that anything when the PA pressure goes about 20, there is a disease. And previously, we had left 20 to 25 millimeter as a borderline situation. But it is found that even when the PA pressure is from 20 to 25, those diseases are going to progress. Majority of them, it was found, many of them, not all of them. So therefore, it has been decided now that the PA pressure more than 20 should be considered pulmonary hypertension. It's a pre-capillary and post-capillary. You know that when the wedge pressure is less than 15, we say pre-capillary. In that situation, PVRI is also less than 3 units. So when the PVRI is more than 3 units or the wedge pressure is more than 15, we say there is a post-capillary hypertension. And to complicate matters, when there is a post-capillary hypertension, there could be pre-capillary component to it also. So there could be a combination of pre and post. And everybody is aware of those 5 groups of pulmonary hypertension. Whether only pre-capillary, we say group 1, only left heart disease, we say group 2, lung disease is group 3, CT-EPH is group 4, and 5 are combinations. So it is good to think of pulmonary hypertension in terms of physiology. Then we talk of transpulmonary gradient. So if the transpulmonary gradient, that means mean PA pressure minus wedge pressure. So when the transpulmonary gradient is more than 15, we say there is a pre-capillary component. People find diastolic pressure gradient better than transpulmonary gradient, and diastolic pressure gradient is PA diastolic minus PA wedge. Normal diastolic pressure gradient is only 1 to 2 millimeter. That means normal wedge pressure and diastolic pressure are very near to each other. If the diastolic pressure gradient is more than 7, then we say pre-capillary component is present, the vascular changes could be there. You know, pulmonary vascular resistance is measured by mean PA pressure minus wedge divided by cardiac output, or a QP in shunt lesions. And index, so there is a common error that when we index, we say PVRI. So it is multiplied by body surface area, not divided by body surface area. So PVRI is so many units into square millimeter. So therefore, in a child, into square millimeter decreases the PVRI. In an adult, it increases the PVRI. So you must be mindful of that. Pulmonary resistance, like any fluid resistance, depends on 8 NL by pi R4. So anything which changes the caliber of the vessels, R is in the denominator to the power of 4. So mild hypoxic vasoconstriction can make a lot of difference to pulmonary resistance. And one thing which is forgotten is viscosity. At NL, N is for viscosity. So when the viscosity rises, the pulmonary resistance rises for everything else remaining same. So this is relevant in a patient with Eisenmenger syndrome. When his hemoglobin goes to 20, 25, venous section there could substantially change pulmonary vascular resistance and can improve the patient. Another thing which nowadays we have come to understand is that beyond pressure, the pulmonary compliance is also a marker of RV afterload. Right ventricle has to work, and it works on pressure, but beyond pressure also the compliance of lungs could be another added thing for RV afterload. And we measure pulmonary compliance by stroke volume of the lung by pulse pressure, which means wide pulse pressure have a more will have pulmonary compliance. It will be influenced by that. So stroke volume by pulse pressure, depending on the value, we will get an idea of a pulmonary vascular compliance, which is the added thing to the afterload as an idea to think. We will expand on this little later. So just for the beginners, see, I'm pitching this lecture for somebody who is not very exposed to these patients. For somebody who is very well into this, this is maybe very basal. So you have increased PA pressure, but no pulmonary vascular disease. When does that happen? So when we have increased flow in the lungs, so increased flow because of high cardiac output, patient pressure will go up, but there is no vascular disease. When you have wedge pressure increase, there is a back pressure transmission. The PA pressure are increased, but there is no vascular disease. So increased cardiac output, for example, with anemia, does it raise PA pressure? Yes, for sure it raises PA pressure. Left heart disease will raise PA pressure. In both the situations, if you calculate PVR, it will be normal. So it could be, but when the pulmonary vascular disease supervenes on them, that there is added precapillary component and PA pressure will rise further. So hence, thinking of PVR is very important. Can you think of a situation when there is a pulmonary vascular disease, but PA pressures are normal? That's very odd. Now, but that happens basically in a Fontan circuit, something like a Fontan circuit. It could happen that the pressures are so low, but still there is a vascular disease. And it could also happen sometimes in a thromboembolic PH, because the thromboembolic pH is not occupying enough area to cause rise in pressure, but the disease could still be there. So it's good to think, you separate the pulmonary pressures into components and think about it. And the patient with PH could be having a heart disease or vascular disease or portopulmonary hypertension, etc., etc., etc. And in the exam, you're supposed to think which is which. So just one question for you for thinking just now. Which of the following conditions in the lungs will not show plexiform lesion on biopsy? So you have a lung biopsy, and which of these following will not show plexiform lesion? And that is, I think, one of the reasons the way we group things. So PSS patient, mitral stenosis patient, Eisenmenger AST or CTE-PH, which of these will not have plexiform lesions on biopsy? So you keep your answers and maybe you can post it, and then we will see whether the answer changes at the end of the lecture. Now, when you have a patient, before we get into the auscultation, etc., you have a patient and you see the face first, and then you think about pulmonary hypertension. So let me ask you some questions. Patient with Down syndrome has no heart disease. Does he have PH in the absence of heart disease? Yes, surely they have. And because of developmental disorders, because of several reasons, recurrent aspirations, lung disease, primarily it's a developmental issue, and they are prone for PH even in the absence of heart disease. A patient with Noonan syndrome on the far left, more known for pulmonary stenosis, do they have PH? Yes. Resopathies, all the resopathies like Noonan's and neurofibromatosis 1 are also complicated by PH in some proportion of patients, not very common. The one on the far right, top right, is a patient with supravalvular PS, it's Williams syndrome. Do they have PH? Yes, they could have central PH because of bilateral peripheral PS, and the RV faces the afterload. Then you have a skin lesion of sarcoid. So sarcoid of PH for multiple reasons: lung disease, mediastinal fibrosis, compressions, etc., etc. Obesity, PH, DVT with PH, sickle cell. This is the lower right is the sickle cell. Can you see my pointer? Probably yes. Yes. So this is venous ulcers with sickle cell anemia with PH. Hand-heart syndromes have PH because of developmental thing. When you saw like the Holt-Oram syndromes and the rest. And in the center, you have a patient with chronic hypoxia at high altitude, and they have a chronic mountain sickness with PH. Liver disease, you know very well, could be PH. Hereditary hemorrhagic telangiectasia. With the telangiectasia, they have often pulmonary AV fistula, but they can also known to have PH. So a patient with pulmonary AV fistula and PH, if you close the fistula, what happens to PH? The PH could worsen because you have reduced the low vascular shunt there. Upper airway obstructions can cause PH. PDA-PH, differential cyanosis. One question in the exam is why the right arm is blue, and how often the right arm is blue in a PDA Eisenmenger. 50% of them can have right arm blue also. And you can think why it is so. PSS scleroductally can have PH. And one thing which we often forget is emphysema. We pick up emphysema on chest X-ray and we don't pick it up on a clinical exam many times. This is the X-ray of emphysema, and that can contribute to PH. although not a primary lesion. But so we should be keeping in mind on physical examination some of these things. So when we see a patient, what are their symptoms? Typically, PH patient have dyspnea, fatigue, syncope, angina, hemoptysis, and later on ascites, cyanosis, and all the symptoms of causal disease. You know this. Now, question to some of the residents is, what causes dyspnea in PH? Yeah, I've been quite disappointed anytime I ask this question, what is the cause of dyspnea? Cardiology resident almost equates dyspnea either with PVH. A better student says skeletal muscle low perfusion. But nobody really tells fully that dyspnea, how do you define dyspnea? Dyspnea is very complex. Dyspnea is defined as a subjective experience of breathing discomfort consisting of qualitatively distinct sensation, which varies in intensity. So quite a complex definition, subjectively distinct sensation, a subjective sensation, distinct quality and varying in intensity. So there are different language of dyspnea, and we tend to equate dyspnea only with PVH. A great student like Preetham, if you ask, he will say J receptors. And J receptors, then the question comes, who discovered J receptors? I think it's good to know. Paintal discovered J receptors, one of the less common, Indian contribution to world literature. So J receptor is the cause of dyspnea in PVH, but dyspnea in PH patient, dyspnea in pulmonary hypertension patient is very complex. It is not only because several of patients have no low cardiac output, but still they are dyspneic. So it arises from skeletal muscle, from the lungs, from the CNS, from the peripheral muscles, and so on and so forth. At the end of the day, dyspnea occurs when the brain gets afferent sensations different from what it expects. And so therefore dyspnea in a PH is quite complex. And we don't think of this, but different dyspnea can be differentiated from the language of dyspnea. Some patients will take that they have difficulty in breathing, it takes more effort. Some people will say they feel tightness, and some people will say air hunger, I can't get enough. And this could actually have potential different diagnosis. And you should also know how we measure dyspnea, how we objectify dyspnea. Several dyspnea scores are there. Some of these names are useful in the exam. MMRC scale, dyspnea 12 scale, etc., etc. Similarly, what is the mechanism of angina? This is easy. What is the mechanism of syncope? Because PH, the output is fixed. So on exertion with peripheral vasodilation, RV cannot cope up, increase the thing. One more thing which all of you probably know is that the left main coronary artery get compressed, sometimes can cause angina, and that can be relieved with stent. So that you would probably know. Hemoptysis is not that well understood. Hemoptysis in tetralogy and hemoptysis in PH. Is there a similarity in the two? That means, can we close it by a coil? Can we treat the hemoptysis of Eisenmenger syndrome? Yes, very much so. Some of the Eisenmenger will have a bleeding from a major vessel rupture, and that is untreatable, practically death. But some of the hemoptysis also arises as the vessel closes down. Just like tetralogy, they develop bronchopulmonary collaterals. And so therefore, there may be a case where we can coil a Eisenmenger with hemoptysis. Hoarseness at the bedside, can you diagnose the cause of hoarseness? Yes, at the bedside by a bovine cough. You can say this is left recurrent laryngeal paralysis. Of late, people have talked of bendopnea. There is only one series where it says bendopnea. That means getting dyspneic on bendopnea has been reported in IPH patient also with some theory about mechanism. It's not a very common thing, but it may be good to know. Could you have orthopnea in PH patient? Most of the time, late PH patients show orthopnea because of large pulmonary artery compressing on trachea. So, and rarely in a very late case, there may be LV dysfunction. So orthopnea, PND practically excludes the IPH, but it could happen for mechanical reasons. So it's probably, most of it probably you should be knowing. Now, when we examine a patient, what do we find? We have a RV type of apex or LV type of apex. And I think many of this will be dealt with in different lectures. You have cardiomegaly in many of the PH when there is a lot of TR. But remember, Eisenmenger VSD and Eisenmenger PD do not give cardiomegaly. Now, when it comes to parasternal heave, I think for a student, it is good to know parasternal heave should also be distinguished like a volume heave or a pressure heave, just like we do in apex, whether it's a heaving apex or a hyperkinetic apex. Similarly, parasternal heave should also be thought of as a pressure load or a volume load. Sometimes in a thin chest individual, when people are not been examining them and then just seeing 2 weeks before exam, you find parasternal heave in everybody. So it's just an impulse is different from getting a heave, and a heave is different when you get a late heave is MR, but when you get a heave, you have to think of volume heave because of a ASD high volume or a VSD high volume, TR high volume, or a pressure load from various reasons. Now, let me also point out that a patient of severe aortic regurgitation, when there is a large LV which goes behind, sometimes it gives a sensation of a heave, which is basically in systole, it will go away, but it can be misinterpreted as a heave. So a patient of AR, remember that you must be very sure that whether the heave is there or not. And most often it will not be there. Palpable P2. Now, when you say palpable P2, one should distinguish it from palpable pulmonary artery, whether it is the sound which is palpable or the artery which is palpable. Palpable S3, S4 could be there. Pulmonary artery pulsations will be really very useful to diagnose PAH. Peripheral bruise. What is the commonest cause of bruise on the lungs in a patient of PAH? We'll come back to that. And a continuous murmur in axilla, one should think, should also go for lung findings and pleural effusions, etc. Now, at the bedside, there is nothing compared to P2. And I think the whole diagnosis in clinical cardiology, auscultatory cardiology, rests on your assessment of P2. And it is surprising how often you are right if your assessment of P2 is right. Nowadays, stethoscope cardiology is getting a backseat. But if you practice it and you realize it really works. So when we say loud P2, we say it when compared to A2 or when it is heard at the apex. When it is palpable, it is going to be loud. And the split becomes closure as the P2 goes up. Why the split becomes closure? Because hangout intervals becomes less and less. P2 assessment is very important. When it is heard at the apex, it is causing PAH. But when it is not PAH, despite being heard at the apex. So when the RV is apex forming, like in ASD, you could have a no PH, still the P2 could be loud at the RV. Any other cause where the RV is making the apex, P2 can be heard at the apex, but it is not equal to PAH. Ejection click is a constant click in most of the PAH. Rarely in Eisenmenger, you can get a phasic click as written by Perloff, but everybody doesn't agree to that. So if you find a patient where you find an inconstant click, but patient is PH, you can give this reference, but it's a very rare finding. Most of the constant click in PH, most of the clicks in PH because of dilated PA is constant. Now, when you have murmur of TR, that is easy because TR murmur is one great way of distinguishing between hypertensive TR and normotensive TR. Does PA pressure, does PH give you ejection murmur? Dilated pulmonary artery might give you a faint murmur, grade 1 or 2 murmur. Any murmur louder than grade 2 cannot be attributed only to dilated pulmonary artery, and you have to find another cause for it. Now, when you have a PR murmur, you can tell the PA pressure indirectly, and I'll just come back to that. So some of the recent studies have shown that if you hear a P2, mostly you hear P2 only on the second space. If you can hear P2 distinctly differently, and even if you hear it at the apex, the pressure is at least 75 millimeters systolic. And this has been validated, so it works. So if you have a PA pressure at the apex, I mean S2 heard at the apex, P2 heard at the apex, you can hazard a guess that the PA systolic should be more than 75, except in a patient of ASD. So when you auscultate, I think the primary thing is normotensive TR versus hypertensive TR, because that is something which you can easily do. So should you have a patient with the early systolic murmur, a TR, you know PA pressures are not raised, versus a continuous pen systolic murmur for hypertensive TR, at least one thing we can say PA pressures are raised. Similarly with pulmonary regurg, a hypertensive PR on the left is like an AR murmur, and it's a decrescendo murmur of high pitched, whereas the normotensive PR is a murmur of P2 which starts after a gap from P2 also. So this is a murmur. Whenever you get this murmur, for example, in a post-op tetralogy or in a absent pulmonary valve syndrome, it's not well appreciated that this is actually also a crescendo decrescendo murmur. Commonest diagnosis for this kind of murmur initially is the mitral stenosis, because this murmur looks so different that you don't think of PH when you have this murmur. So you have to see this once or twice to recognize, and then it's a stethoscope diagnosis. So normotensive PR murmur with a split second sound away from the second heart sound, and a murmur which is either a crescendo decrescendo or at least not a high pitched murmur. It's a medium to low pitched murmur. So these are the places where you can say PA pressure is not raised. Question: if you have a PR type of murmur, and if you have peripheral signs of AR, you have periphery wide pulse pressure, but there is no AR on echo. What is the diagnosis? Patient has got a wide collapsing pulse, but there is no echo. Echo shows no AR. And this situation happens when there is a PDA PH with PR. So PR murmur because of a PDA can give you wide pulse pressure outside. It's a common trap. Sometimes you can get into it. Okay. Continuous murmur on the lungs. Commonest cause of continuous murmur on the lung in acquired form is because of a thromboembolic PAH. I've seen patients like this, and it is real. See, in a baby, you think of peripheral pulmonary stenosis, multiple peripheral stenosis, Ehlers-Danlos syndrome, supravalvular PS. But in an adult in acquired form, a thromboembolic PAH is a common cause of continuous murmur. So we should keep mindful of that. So often you will find that you have some findings and you say, okay, finally it was this, why my findings were wrong? So commonest cause of your finding is wrong is because you have been told the diagnosis and you did not synthesize it yourself. So if you avoid that bias, then we could have got into diffuse atrophy. We did not think hard enough. And there was some genuine trap. So common trap in a PH patient is that you had a PA, you thought a palpable pulmonary artery in the second space, it was actually a aorta of LTGA. And that's a typical trap. So we were not thinking hard enough that things are not fitting. But more importantly, what we find in our daily practice is that, one thing says something, another thing says another thing. So you will feel this in every case, that some findings are in conflict with another finding. So then you have to go back and you have to apply the hierarchy of reasoning. What is the more important finding? What is the hard finding on which I can latch on? For example, you have wide pulse pressure, so that is definitely there. Whereas my P2 may be incorrect because my P2 I have not been very seriously looking. Or you take the other stand that, oh, this is the wide fixed second sound. So there must be some reason for wide fixed second sound. Maybe I'm not finding anything, so maybe it is RBB there, whatever else. So you have to think hard enough, and your own findings should fit with your own findings, your own reasoning. I do not think anybody pass or fail because of the diagnosis, but your own reasoning should be in consonance with what you think. So, and that is important for every case. So coming back to PH, every case you will be asked what is PVH, PH severity, mild, moderate, severe, etc. And you know the gradations and diagnosis. Now there are two disorders where you can clinically tell at the bedside what is the pulmonary wedge pressure. In AST and in CCP, you know the JVP and you can guess what is the wedge pressure. And from the wedge pressure, you can calculate the PS systolic, back calculated depending on the situation. It is also said that in a cardiomyopathy patient, your PS systolic pressure is twice the wedge pressure from the large registry data. So if you guess a wedge pressure of more than 25, systolic pressure commonly, this varies, is more than twice the PA pressure. So these are some of the tricks which can help you in getting what is PH, PVH. So once you have a patient of PH, we see X-ray, ECG, echo, and other things. So I'm not going to details because of the time, but I have kept for you a couple of points. Like I am showing this ECG I got from a very old book. So you find a ECG in a patient where you find inferior MI and anteroseptal MI simultaneously. What is the diagnosis? You have a ECG of a patient in casualty who is breathless, has inferior MI and anteroseptal MI. Should you face this situation, remember pulmonary embolism. This is the situation where you can get stress changes in the anteroseptal, because two MI together is very rare, can happen, but you will be more often than not, you may probably be getting into pulmonary embolism. How do you identify RA dilatation in patient with AF? Another question is there. I'm not putting that ECG. Diagnosing RA dilatation in AF by a Q wave in V1. Another, is this RVH or LVH? Poor progression of R wave, could be RVH or LVH. It is called as type C RVH, and sometimes in emphysematous patient you find this. So these are just 2-3 points about ECG. When you come to X-rays, because you have several different sessions on X-ray ECG, I am not getting into details. So you are supposed to say PVH, pH, plethora. Do not confuse PVH with pH. I mean, I'm sure students in South India are much brighter, so they wouldn't do this. Do not confuse plethora with pH either. See the secondary cardiac effects, and there are etiological clues on the lungs. No details on the lung X-rays, just I'll show you two findings which are often less discussed. You know the dilated pulmonary artery more than 16 in males and 15 in females. You also know that descending pulmonary artery larger than trachea in children is a sign of PH. Pruning is there. So pruning is organic or functional? Can there be pruning of the lung vessels in a functional PH? Means vasoconstriction PH? Yes, very much. Pruning is not a sign of organic changes. Pruning can happen in functional hyperkinetic PH also. Hyla, if the hyla, suppose the dilatation is still hyla. So hyla to hyla, if it is less than or more than 44% of the internal chest diameter, that is also an old sign of PH, less well emphasized. And another thing about RA, which is less often heard, RA dilatation is very difficult on X-ray. Sometimes it is masquerading, but this is a good sign of RA dilatation. That 2.5 is not as good as this one. That means if you draw a line at a SVC RA junction and another line on the top at a aorta, arch of aorta top, if the distance A is bigger than distance B, it is a good sign of RA enlargement. This is better than the 2.5, because 2.5 from midline is often influenced by other dilatation also. So just I have picked up two things which are less well emphasized, and other things about X-ray, I'm not getting into the details. Okay, this is just one interesting X-ray. The X-ray on the left, can you see the RPA? Is it a dilated RPA? Not dilated RPA. Could this patient be having PH? Suspicion is there because the main pulmonary artery is dilated. See the CT scan on the left. This is the thromboembolic PH. The PA pressure, the PA thrombus has shriveled the pulmonary artery. So from this X-ray, one could have guessed the focal oligemia and a shriveled pulmonary artery, an unusual example of a thromboembolic PH on chest X-ray. You can interrupt me if I'm making no sense. Just 1 or 2 points about echo. Which of these two patients is in a bed clinic? Both are PH, both have a TR velocity of about 4 or maybe 4. Which is worse clinically? So from this echo, can you tell that? Yes, the one on the right is having worse because there is a worse DPDT in that. So RV function is worse on that because the DPDT, as you can calculate from tricuspid regurgitation jet, is worse on the second one. So TR often has a lot of things to be said. TR is not to be relied upon if the jet is not very good. If the TR is more than 3.5, then you know certainly PH is there, but you must not over-interpret TR jet. Sometimes in the beginning you make gain setting improper. So TR jet should be very good jet to really tell about the PA pressure. And one thing which I just bring to your notice, when the TR is gross, that means suppose there is a traumatic TR with wide open tricuspid valve, then this Bernoulli is not applicable. I have seen this time and again people making this error. When Bernoulli is applicable only when there is a flow of that nature. If there is an unguarded tricuspid orifice, for example, then Bernoulli is not applicable. You will invariably find a normotensive TR, but which is not the truth. Of course, the RA is raised and IVC is dilated, so RA pressure is to be added. But other than that also, if the tricuspid is large and fully gross TR, Bernoulli is not applicable. This is more emphasized nowadays. You know, this PA, you must get a Doppler in pulmonary artery and guess about how the flow is happening. And I think everybody knows that acceleration time, the shorter the acceleration time, the poorer is the condition, the worse is the RV function. So when you put a Doppler in the PA, it's very brief flow if the PA pressures are raised. And it said that acceleration time less than 105 is suggestive of PH. As the RV function fails, the pre-ejection period goes up, ejection time becomes less, and the jet you get is brief and brief. So I think when you are looking at operability, etc., it's also a good thing to look into the Doppler in the pulmonary artery. If you have not heard of this, this is very interesting. If there is a mid-systolic notch in the pulmonary Doppler, it is suggestive of a PAH. Can it tell you about the type of PAH? Yes, it is supposed to be more common in pre-capillary PAH. When the PH is post-capillary, you don't often get a notch. The notch is probably a reflection from the pulmonary vasculature. Perhaps because of a non-compliant PH, it is said that the late notch is probably more in thromboembolism, but that is not very, very clear. So should you find a notch like this in the pulmonary artery Doppler, it is highly suspicious of a pre-capillary pulmonary hypertension. So normal Doppler flow is triangular with a long ACT more than 105 and has no notch. If you find a notch, think of pre-capillary PH. So these are, some studies have shown some percentage of cases. These are not very hard data, but this is how clinical thinking evolves. You put so many things together and get into the business. We should have some idea about the basic tests. I think one which is less often emphasized is PFT. Cardiologists should have a working knowledge of PFT, DLCO, and ABGs in patient of IPH. What is the ABG of a patient of IPH commonly? They often have a mild decreased PCO2. They have a mild dysfunction of PFTs, mild restriction. And DLCO, if it is significantly reduced in absence of a significant lesion on the lung on CT, that is highly suspicious of PH. If it is very, very reduced, then it is almost diagnostic of, in the absence of lung disease. If DLCO is markedly reduced, then your diagnosis should be veno-occlusive disease or capillary hemangiomatosis. So basically, thromboembolic PH or IPH, DLCO is reduced. If it is accompanied by lung disease, then emphysema, etc., is causing reduced DLCO. What is the cause of increased DLCO? Shunt lesions can cause increased DLCO, etc. So you should have some working knowledge of DLCO. HRCT gives everything about it. VQ scan, gold standard for ruling out thromboembolism, VQ scan. CT angio is everyday's bet. And one thing which is missing from our armamentarium is cardiopulmonary exercise test. Since we don't do it in practice, but a bit of knowledge about cardiopulmonary exercise test should be there to understand the physiology and to distinguish a complex patient where there is a mixture of lesions or whether there is a diagnostic dilemma. What is the uric acid in IPH? Uric acid is raised in patient of PH. BNP is raised in patient of PH when there is RV dysfunction. Why uric acid is raised is an interesting question for you to read. Cardiac catheterization should not be done in a very sick PH patient, or should be done only when you are comfortable because it can kill. A patient with PH should be respected when you take him to the cath lab. You should be very careful because because they have very less, the system is totally fixed. Any slightest, maybe by a way of indulging an arrhythmia or anything, can tip off the balance. So cardiac cath in a PH should be taken very seriously. Yes, it is recommended to be done for getting one baseline test, and it will be useful when you have a diagnostic doubt. Genetic testing for PH, we do not do it. I do not think it should be done unless there is a reason to do that. And there are disease-specific tests which varies with the situation. Now, a couple of things about, let us see about how do we go about thinking about a PH. So you have a patient with pulmonary hypertension. We say when the wedge pressure is 15 or above, we suspect left heart disease. So this slide is basically to show you the disconnect between wedge and LV-EDP. The picture on the left shows that as many as 50% patient in this about 3,000 patient data had a disconnect between wedge and LV-ED, which means wedge was not the reflection of PA LV-ED, and for many reasons, for several reasons, and many of them, zeroing and practical calibration, and also for several other reasons. So wedge may not be reflecting LV-ED all the time. Then other difficulties about good wedge pressure, whether you take a digitized mean or whether you take an end expiratory mean. So a wedge pressure should be taken at end expiration. It is not a mean wedge pressure; it is the end expiratory end diastolic wedge pressure. And wedge can be influenced by diuretics. So you have a patient, for example, his wedge is 20, his PA mean pressure is 50. You give him a good dose of diuretic. Now wedge becomes 11. And PA mean pressure also falls. So, but this is PH. So now if you were to catheterize him when the wedge is 11, you can wrongly group him as not left heart. So how do you get around this? So you have to take total picture. Sometimes you can give a saline load. So what is the recommended saline load testing? You give 500 ml of saline over 10 minutes. And if the wedge pressure goes above 18, we say there is a raised LV-EDP or the left heart disease is there. So the limitations of keeping wedge only as a diagnostic criteria. There could be limitations of, so we have taken, PVRI into account. So PVRI more than 3 is also kept. But even there could be disconnect. That means you could have a patient whose PVRI is raised, but wedge pressure is showing something else. So nothing in isolation is going to solve all the clinical problems. We have to take total picture into consideration. So here is a patient with a wedge pressure of 25. This patient is now because of left heart disease, because hypertension, metabolic syndrome, etc., etc. So one of the wedge pressure 25 has a transpulmonary gradient of 8, RA mean of 5, and has a mild PA pressure. So this is a post-capillary type 2. The same patient or another patient with a 25 wedge could have a transpulmonary gradient of 17, giving him a PA mean of 42. He is facing a higher afterload, and his RV is failing. His RA mean is going to 15. He is in gross congestive heart failure. So this is an example of a combined pre and post capillary. So what has happened in this patient? The increased wedge pressure has somehow triggered some things in the lungs, and he has developed changes in the lungs of vascular, whatever we call as type 1 PH. So this is a combined pre and post capillary patient. So there is a phenotype of a patient with left heart disease, maybe let us say a normal systolic function patient, a diastolic heart failure patient could have a PA artery pressure mean 30 or mean 40, RA mean of 5 or RA mean of 15. So there is a nice distinct phenotype of diastolic heart failure described where we can have a severe PAH. So the question then is, can you see the PA pressure and see? Because our general feeling is that in diastolic heart failure, PA pressure rise but doesn't go so much. So this is a study from large number of patients, and it shows that the mean PA pressure could be as high as pressures in PAH. So one phenotype of a diastolic heart failure also can give you severe PAH, meaning thereby that by the quantitation of PA pressure, you cannot distinguish the two. So you have to put everything together. So you can one day find a patient with diastolic heart failure who mimics the serious PAH group 1 patient. By and large, we see that if we have evidence of diastolic dysfunction, we have LA enlarged, we have a background for that thing of patient, then we think of part type 2 and we don't give them vasodilators. So you should be aware of the fact that a phenotype of diastolic heart failure can have a severe PAH, which mimics a pre-capillary PAH. But more problem on exam is basically RSD patient. So let me just talk 2 minutes about the mitral stenosis patient. So what is the PVRI in mitral stenosis patient? You have a patient with mitral stenosis, you catheterize him, you do hundreds of mitral stenosis, BMV, etc. What is the PVRI in them? So you write your answers, you tell it to Dr. Bhupati and Dr. Preetham. You know PVRI in MS could vary. There could be a patient with a normal PVRI and there could be a patient with a very severe raised PVRI. That means the secondary changes in PVRI in the lungs is so much that they could have a suprasystemic PA pressure and the PVRI can be very high. Now, what is the lung changes in them? What happens if you see the lung biopsy? Do they have a plexiform changes? Is this PVRI reversible? So if you treat this patient if you treat the mitral stenosis, majority of the PVRI goes down. How fast does it go down? It goes down very significantly faster. A small minority of PVRI, a study from Chitra has shown that a small minority PVRI may not fault fully and may have a precapillary component, but they are less. We might not have opened the pulmonary vasculature fully, or they might have developed some lung disease in them. By and large, mitral stenosis PVRI. So PVRI raised because of lung inflow disease is largely reversible. When do you get PAH in mitral regurgitation? Not very early. So it's a late manifestation. It is often because of LV dysfunction. And S2 is wide split in mitral regurgitation. So even when they develop PAH, sometimes you can have a P2 split wider compared to normal PAH. So you could have loud P2, which is wide split because of MR. We don't think of PAH in aortic stenosis, but if you read the literature, 10% of aortic stenosis patients are described with severe pressure, severe PAH, because of, again, LV, ADP raised, etc. So you could potentially have a normal, a patient with AS only with back pressure changes, and just like mitral stenosis patient. In this patient, sometimes LV-ADP and patient with AR also, the LV-ADP can be higher than PA wedge because of premature closure of mitral valve. So that is another typical exam question. You have a TR patient. Now, the other question sometimes come when you have pensystolic murmur of TR, pH is there. So is it a functional TR or organic TR? Now, typically we say it's a functional TR, but that is not very true, because a patient is having a pH from mitral stenosis can also get organic TR. So seeing a pensystolic murmur in TR is not always a sure sign of functional TR. Suppose that patient has the evidence of TS, it's organic TR. So, and you could have on autopsy organic changes in TR in a RSD MS patient and up to 20 to 30%. Echo can show organic lesions, thick leaflet and looming. But at a bedside, we know that pH is there, and this TR is suggestive of pH. Functional or organic, we need to think from other things. Now you have a JVP which is pulsatile. What is the PA pressure in a very pulsatile? So you have a liver pulsatile with JVP. Does it mean PAH? Not really, because pulsatile liver can come from a normotensive TR also if it is severe. So pulsatility by itself is not a sign of severe PH, it is a sign of severe TR. Congenital heart disease, you have separate sessions of congenital heart disease. We will just talk of a couple of things. So your patient could be having PS or a PH, or he may have normal PA pressure, neither PS nor PH, and have several congenital heart disease. You know this grouping. Now you have PH. How do you decide it is hyperkinetic or obstructive PH? So that is simple. If you have evidence of a increased shunt, so impulse is hyperkinetic. You have wide second sound, and the evidence of a shunt murmur is there. Shunt murmur in a AST could be at the second base area, second intercostal space, or a tricuspid flow murmur. In a VST, it is a mitral flow rumble, or in a PDA also it could be mitral flow rumble and a murmur of PDA. So if you have murmur of VST, PDA, AST, and a shunt murmur, then we know flow is more than 2:1. So if the flow is there, the pH is there, it is a hyperkinetic pH. Conversely, we do not have evidence of a flow rumble. There are no significant murmur, and the second sound is P2 is loud. So this is the obstructive pH. We think of Eisenmenger. This is relatively easy, but sometimes mistakes are made in this. So I have put it here. Often you get an AST in an exam, and let us see what happens in an AST, in adult ASD. So you have an ASD patient who is blue. Well, how do you think of ASD with a blue patient? So if he's blue and P2 is loud, you can say this is Eisenmenger, can you? So loud P2 by itself does not tell you pH. If the same patient has a ASD cyanosis and has good flow murmur in the second space and a tricuspid flow rumble, what is your diagnosis? It should be TAPVC, or it could be other causes of cyanosis in an ASD with normal PA pressure. So there are several causes of cyanosis in ASD with normal PA pressure. You have to think in one of those. If you have no murmur, significant murmur of ASD is not there, patient is bluish, and there is loud P2, and cardiomegaly may not be there. TR, if it is there, it is hypertensive TR. So then this is the Eisenmenger ASD type of situation. Often you have AF and patient is not blue, or patient may be mildly blue. In adult ASD, often present with TR. You rule out thyrotoxic, and then it is AF because of ASD. Now that patient may not be blue or may be blue, maybe slightly blue despite no Eisenmenger, or maybe blue with Eisenmenger. So you have to look for the flow rumble as a sign of hyperkinetic versus obstructive. ASD is a good case to think of all these variations. So you have a peristernal heave. Is the peristernal heave type of a volume overload or pressure overload? Is there cardiomegaly or no cardiomegaly? Things like that. So sometimes echo might miss sinus venosus ASD. So Eisenmenger, occurs in a less number of patients of ASDs, and it is unlikely after 5th decade. So that means if the patient did not have Eisenmenger in 3rd, 4th decade, it is not likely that he will develop Eisenmenger later. So how do you assess pH as we just discussed? So for pH in ASD, don't rely on the second P2 loudness only. So what happens to fixity in a Eisenmenger ASD? It remains fixed, but it becomes narrow. So previously, if it was maybe 100 millisecond, now it is 40, 30. What is the human ear split? It cannot hear a split below 20 milliseconds. So that same patient has a thrill on the base. Suppose the ASD patient has a thrill in the second intercostal space. What do you think? So thrill in a patient of suspected ASD or a patient with a wide fixed second sound should mean a large flow. So large flow in ASD can come because of 3 things. So large flow means a thrill. So either it is a valvular PS in addition, or there is a mitral valve lesion, MS or MR, causing an increased flow, or there may be some patient with ASD with very high flow, causing a thrill. And if such patient has cyanosis, you think of TAPVC or other causes as we discussed. Is it Eisenmenger or a tetralogy? This is a common clinical issue. I think a separate lecture may be done for this. But very briefly, you have a sinus patient, and since both have a single second sound, how do you say it is pH or no pH? From single second sound in tetralogy or single second sound in Eisenmenger, you cannot tell pH. Common mistake is parasternal heave. Both do not have parasternal heave. The only finding which helps here is palpable pulmonary artery. So if you have palpable pulmonary artery or a high-pitched murmur, diastolic murmur PR, you know this is pH. Clinical pointer is that the cyanosis for the same degree of thing is not very severe in Eisenmenger. Eisenmenger to become very blue is very late, whereas the tetralogy, which is like that, is not very, is very blue and has a faint murmur. You know, the murmur in tetralogy correlates inversely also with cyanosis. So you have no cardiomegaly in both, no parasternal heave in both, single second sound in both, ejection click could be there in both, but pulmonary artery is not palpable in tetralogy and it's palpable in Eisenmenger. Same thing here. ASD Eisenmenger, you could have a large pulmonary artery. Now, pulmonary regurgitation murmur, high pitched there, is more often in a PD Eisenmenger. So I hope none of you talk of this Eisenmenger in 1st decade, 2nd decade, 3rd decade in VST, PD, ASD. This is a misconcept from Paul Wood initial. This thing was about the presentation. They all become Eisenmenger very early in life and they all need surgery very early. I mean, they all miss VST and PDA. So how do you distinguish VST, PD, ASD, Eisenmenger at a bedside is a common clinical examination question. So what is the large VST? A VST which is bigger than aortic annulus is large. 8 millimeter is a large PDA and 2 centimeter is a large AST. Single second sound in VST, normal split second sound in PDA, and wide fixed but narrow fixed in AST. No cardiomegaly in VST PDA, but cardiomegaly in AST, and a murmur of PR more often in Eisenmenger PDA. Differential cyanosis in a PDA, but no differential cyanosis in 50%. One should read that Paul Wood prime original series before going to exam, and you can quote some percentages. This is not absolute. So 50% of PDAs do not have differential cyanosis. In that series, about 50% had only single second sound. So it helps to quote some figures. Now this X-ray shows one particular phenomena. Is this a Eisenmenger or no Eisenmenger? VST Eisenmenger. Most Eisenmengers will have increased, telltale evidence of increased shunt. 10% of Eisenmenger patients have gone through persistent fetal circulation directly as Eisenmenger. They never had any problem in neonatal or infantile life. So they were first picked up as Eisenmenger. So it's an unfortunate thing, but it happens sometimes that the patient first comes to you at a 14, 15, 20 years when he's Eisenmenger. And see, the X-ray gives no clue to a previous shunt. So one keep in mind that there is no history of previous increased flow also. So this is persistent fetal circulation has occasionally happened in an Eisenmenger patient. From X-ray, you can say ASD, VST, PDA. X-ray of ASD is a small aorta, large heart, very, very dilated PA. PD Eisenmenger, one can see the PD hump there. It may be calcified. And a VST Eisenmenger in between. Remember, the telltale evidence lag behind the Eisenmenger. So you can have Eisenmenger with increased flow on X-ray, which is just a evidence of a past increased QP, does not represent an increased flow. Patient of PH, one on the right is a trunk because of a right aortic arch, increased QP, but absent pulmonary artery. So trunk could give you right pulmonary arch and PH. And this one is also a PH because of dilated pulmonary artery and a complex heart disease. Okay. So when you have PDA and you have severe PH, because you all are keen on device, I just want to operability. I'm not going to discuss in detail. There is only one question. You balloon occlude the PDA, you find the PA pressure has fallen. Shall we close or shall we not close? See, sometimes the fall is not very much. So they say to be very comfortable, the fall must be more than 50%. Otherwise, the PA pressure can come back. So should you close the PDA with borderline PA pressure and a little bit of a fall, the PA pressure can come back and then we may be in difficult, we have hurt the patient. So just be mindful of this. So just one example. Here is a patient. If you have seen this before, this is shown by many. So there is a cath of LVED and a PA wedge. LVED and a LA, for example. There is no gradient here. So patient has a RA mean of 13. There is a significant increase in saturation. PA saturation is 90, so there is a shunt. And RA, LA pressures are equal. LA is 14, RA is 20. LVED is 14, not much gradient. So what is the problem? This patient looks like having an ASD. What is against an ASD? When you have RA, LA equal and a saturation of a step up in the atrial level, you say ASD. So why this is not a simple ASD? SVC is only 43. So this is a very sick patient. ASD patients are not supposed to be so sick. So this is a favorite exam question. When you get something like this, you remember Lutem-Bescher, ASD with mitral stenosis. Because of the ASD, you don't get a good gradient. But the clues are a very large flow, and maybe thrill at the base. Mitral stenosis murmur may be totally absent. You may only have a ejection opening snap in exam. Just couple of points about lung disease. See, we often, when the patient is admitted, we say there is a component of LRTI, there is small aspiration. So how much pH actually happens in lung disease? So I've just made few statements from total literature understanding. And remember this, lung disease to cause pH has to be serious lung disease. Garden variety, bit of a consolidation, bit of pneumonia does not increase lung PA pressure unless there is a couple of complicated lesions, unless together things are there. So on experimental thing, 80% of parenchyma dissection is required to produce mean PA pressure of more than 25. 90% of COPD patients have mean PA pressure of more than 20. So if you have to answer which is the commonest cause of PH, I think the first thing will be heart failure, because diastolic heart failure gives increased PA mean more than 20. Second could be COPD, but the PA pressure is only mild. So only 3 to 5% of them have mean PA more than 35 to 40. Progression of pH in them is very slow. But there are some lung disease in which PA pressures become very severe. For example, interstitial fibrosis with DPL, and 10% of them may have severe pH. So some interstitial fibrosis patient with discriminating pneumonias have high PA pressures. There is combined entity called as combined pulmonary fibrosis and emphysema. They have high pH. For lung disease, we have defined severe pH as more than 35 because the lung destruction significant, and therefore we do not wait for mean PA 50 to call severe pH. So for a patient of lung disease, mean PA mean than 35 or mean PA more with a decreased cardiac output is a sign of severe pH. And a patient of lung disease, should he have pH, he is in a very poor prognostic bracket. 5 comments about cardiopulmonary exercise testing, which indicates physiology. So in a patient of a pH, suppose you put him on the cardiopulmonary exercise, what happens? Or in a patient who's breathless, how do you say it is heart or lung? So one way is to put them on exercise test. One simple things which you can remember, that in normal, it is the heart which is a restricting organ. The bottleneck for exercise is at the heart level. Lung is not the cause of bottleneck or a restriction for exercise. So in normal people, VO2 max is more than 80%. VO2 max, less than 10 is very bad, indication of heart transplant. Normal VO2 should be more than 20 ml. VO2 max on exercise should reach more than 80% of predicted thing. Ventilation should not reach 80% predicted, because if ventilation has reached 80%, that means there is a lung disease. Oxygen pulse should be more than 10 ml per beat. Anaerobic threshold normally should be more than 40% predicted. And ventilatory equivalent of CO2 should be less than 30. Saturation should not fall by more than 4% in a normal thing. So if your saturation fall more than 4%, it may be lung disease. So let us see if reduced exercise capacity in both. If the heart rate has risen very much, there is no heart rate reserve. Stroke volume is impaired, anaerobic threshold has come early, and ventilation has not reached limitation. This may be heart disease. Conversely, heart rate did not rise very much, but ventilation reached the limits. Anaerobic threshold came early, and there is a desaturation. So this could be lung disease. And it is a little complex. You can read for yourself, but have some background of understanding about heart cardiopulmonary exercise test. So this is 1957 publication in circulation before the sleep apnea, etc. were well known. So this patient is PH, and you can see the photo on the right, the arterial oxygen saturation is dipping from 90 to 50. What is the cause of PH in him? Type 1, type 2, type 3, type 4, or any? So obesity can give cardiomyopathy, which is less well appreciated. It could be diastolic dysfunction alone. Obesity, cardiomyopathy, diastolic dysfunction, increased cardiac output from obesity, sleep apnea. So it could be anyone, and they are more prone for CTE-PH. So all the 5 are possible for this particular patient. So that only just illustration of how complex things can become at a clinical level. When you get a patient of PH, what are the reversible causes? One should be mindful of. So this is applicable to IPH patient also, because this is what at a clinical level we do. We try to optimize hypercarbia, hypoxia, altitude, any airway obstruction, any part of reversibility in the lung disease, left ventricular inflow obstructions, polycythemia, any drugs, toxins, herbs. Is there any nutritional deficiency as the cause of PH? There are epidemics of PH described from Jammu and Kashmir and also seen from Karnataka, where infants are admitted with PH and they are found to have basically thiamine deficiency or some other vitamin deficiencies. The reason was what? The reason is because it was a high output which masqueraded as PH, and when the heart failed, somehow the RV failed more. So it looked clinically like a case of PH only. There was a disproportionate PH in them. There are few disorders in which right heart is more involved than left heart, and which is not clinically appreciated. Remember, for everything else, if you have much more right failure than left failure, think of primary amyloid. Think of thyrotoxicosis. Thyrotoxicosis causes more TR than MR. Right heart more than left heart. Pyruvate, the thiamine 1 deficiency in an infant, more right heart than left heart, just incidentally. So you would rule out these things: obesity, hyperthyroid, anemia. For everything else, if we improve the anemia, the cardiac output stabilizes at a lower level, and so PA pressure might reduce that way. And there could be disease-specific reversibilities. Sometimes steroid could be used in vasculitis. Sometimes there could be other things like Abernathy syndrome. So this is how we upper airway obstructions, etc. So this is how we really think for reversibility. I'm trying to cover as much as I can cover. I will take just 5-10 minutes more, if you permit. Shall I?
As long as you want, sir, definitely.
So some cases, so I'll skip this one. This is just to show that oxygen study is misunderstood. If your basal PVR is very high and oxygen shows a lot of jump down, do not go for operation. It is a fallacy. Only thing when hypoxia is a primary cause, suppose the child has become hypoxic in the cath lab, PA pressure can go very much, which can come down with oxygen. So hypoxia as a cause of reversibility should be okay. Other than that, resting PVR is very much important. I'll skip this. Operability for PVRA values, I'm not going to there. So this is the case which you now seriously think. This is an 8-year-old, has severe PH, PA mean of 90. PA mean is 90, his PA saturation is 62, and his calculated PVRA is 26, and which falls to 19 on oxygen. Should he be operated? You can write your answers. Want more data. So his PA wedge is 38. Wedge pressure is 38. Despite that, his PVRI is 26. So there is a pre-capillary and post-capillary both. So this patient is mitral stenosis with PDA. Severe mitral stenosis with PDA, has severe PH, Eisenmenger almost. We operated on him, operated his mitral stenosis, PA pressure has fallen dramatically. He is very good, even though resting PVRI has fallen from 26 to 8. This is an old study, we reported this also. So remember, some of the PVR could be reversible if the patient has an inflow obstruction of all nature, congenital MS or rheumatic MS, it could reverse very significantly. We have seen more than one patient like that. Another concept here, severe PH this patient had, hemitruncus. The RP is arising from aorta, but it is protected. So the point here is, as long as you have one normal lung, you combine the two lungs, the PA mean will come normal. 1 by R is equal to 1 by R1 plus 1 by R2. So no matter what is R1, R2, the mean R will come less than the R1, whichever is the lower. If you compute this, let us say one lung is 20 units, other lung is 2 units, your mean will come as less than 2. So as long as one lung is protected. For example, this patient has protected one lung by right pulmonary artery is protected because there is a right pulmonary artery stenosis. Now, if you combine right and left lung, the mean PA pressure at the end will be operable. In other words, patient should be operated. So this is the, can you prove it? Yes, we proved it. We just collected the two lung by a long graft and the patient PA pressure really fell down. Patient did very well. So you had Eisenmenger changes in one lung, left lung, and the right lung was normal in histopathology, and the end result is good. There are not too many of this, so I have shown you to make these two physiological points. One more example, 30-year-old lady with dyspnea, RV pressure 90, no past history of lung disease, DVT, collagen disease, looks like primary PH, and the CT shows CTEPH. So remember, CTEPH looks completely like IPH, unless you are very discerning. Sometimes you might find a history of stuttering course in them, that their clinical worsening is occurring, I mean, in stutters, but it could be very difficult. So, and this patient had a thromboangiotectomy done with a lot of significant clinical improvement. So many patients do not give history of pulmonary embolism. Antiphospholipid antibodies, thyroids, dysfibrinogenemia, splenectomies are risk factor for CTEPH. So patients develop pulmonary embolism, and 95% of them do not develop CTEPH. Acute pulmonary embolism, often you think on ambulatory, but remember this, 25% of pulmonary embolism, 25% occur in ambulatory patients. So the fact that patient was not in the hospital, did not have surgery, does not mean it's not pulmonary embolus. But majority of them resolve by themselves. When they do not resolve, or when they present with CTEPH, there is something wrong in them, which is not only coagulation disorders, which is very different. So you should have a high index of suspicion. So the picture on the left is looking like CTEPH. Which disorders mimic CTEPH on CT? CT. So patient looks completely like CTPH on CT, but it does not have CTPH. This patient is Takayasu arteritis. Takayasu can masquerade CTPH on CT identically. The patient on the right has fibrosing mediastinitis, IgG4 disease, which also looks like CTEPH. So which patient of CTPH should be operated? Patient in CTPH in the area which is obstructed. So remember this, patient with vascular obstruction, distal to that vascular obstruction shows plexiform lesion, contrary to what you would have thought. So in the answer to the first question, CTEPH also shows plexiform lesions. Portopulmonary type 1 also plexiform lesions. Mitral stenosis patient do not show plexiform lesion because, and therefore they reverse. So these two CTs are quite like CTEPH, but not CTEPH, Takayasu arteritis and IgG4 disease. Patient being treated as epilepsy in neuro ward, found to have severe PH. Every night she will throw a seizure, almost look like life-threatening. Studied their oxygen oximetry at night, and after starting oxygen and pulmonary vasodilators, she's alive now for 5 years. So some of the time we should do nocturnal oximetry, and you can, don't trouble the patient if they don't have desaturation, that they need, they don't need home oxygen majority of that time. The life gets messed up. But should they get desaturation on oxygen, should they have nocturnal fall, then oxygen can be handy and useful. Finally, this patient of Abernathy syndrome, everybody talks of Abernathy nowadays. So a patient of IPH, you should think of Abernathy in a clinical context. Abernathy means portopulmonary shunt, portal blood goes to system. Instead of going through the lungs, it goes to the IVC, and you can close some of them if they are treatable. So Abernathy malformation, if anybody does not know, is a blind spot, is a treatable form of PH, where the portal blood is not going to lung, and either they can have pulmonary artery venous fistula or they can have get PH. A patient of PH, we thought PH, we started them on vasodilators and they developed RILES. They had ground glass opacity on CT. The illness was faster than normal, and they had markedly low DLCO2. It could be a pulmonary vascular PVOD. PVOD patient on CT shows lymphadenopathy, ground glass appearance, septal lines, and can be easily distinguished on CT. And they are sick patients, the prognosis is not very good. And they masquerade clinically as IPH, but these are the two disorders in IPH which you put in group 1, but have a distinct prognosis, and the therapy is still not very good. Pulmonary capillary hemangiomatosis, 2 children which we saw with pulmonary capillary hemangiomatosis and veno-occlusive disease, both diagnoses on CT and different profile, and they worsen with sildenafil. There are some sophisticated things. So this is just to remind you of pulmonary compliance in addition to pulmonary PVR. So pulmonary stroke volume, we say pulmonary flow divided by heart rate, or cardiac output divided by heart rate. So you get a pulmonary flow, and that pulmonary flow, that means pulmonary stroke volume, Pulmonary flow divided by heart rate will give you pulmonary stroke volume. Each heartbeat is giving so much ml of flow. That divided by pulse pressure gives you a pulmonary artery compliance. And nowadays, people are realizing that this is a good measure of RV after load. Some idea about which patient of PAH is sick. So now you diagnose IPAH, and you have to have some values in your own mind, which are low risk, which is high risk. So, you know, some cutoffs like 6-minute walk distance less than 165 is very bad. Class 4 syncope is very bad. On cardiopulmonary exercise testing, if the VO2 is not more than 10, I'm concentrating on the last 10 ml of VO2 less than 165 of 6-minute walk, high pro-BNP, high RA pressure, pericardial effusions, mean RA more than 14, and low cardiac index, systemic mixed venous very low. Obviously, these are sick patients, and their prognosis is 10% mortality yearly. Converse with the other lesions. So this is textbook picture. So you should practice some of these and remember some of this for exams. Just last slide. So you could have PA pressure with chronic kidney disease, which I did not discuss much. Because of what? Because of volume retention, because of LVED, because of some pulmonary vascular disease. Patient has raised ammonia and a normal left liver function test, and PAH, abnormal malformation. Has a bruit on the lungs, either peripheral pulmonary vascular disease or a thromboembolic PH. Is worsening with pulmonary vasodilators. Think of veno-occlusive disease or pulmonary capillary hemangiomatosis. The newborn with PH, PPHN, but had SSRI in the mother. PPHN because of premature closure of the duct. Protein C deficiency, maybe had a thromboembolism. Venous ulcer, sickle cell, had a missing left subclavian and systemic hypertension, maybe Takayasum. Splenectomy for whatever reason makes them, predispose them to many things which is causing PAH. Sometimes they have CTPH, sometimes they have, you know, PH from thrombocytosis, sometimes they have for no reasons. So think of PH with high index of suspicion with a dysfunctional spleen. Highlanders, there is a disease called a subacute mountain sickness. When somebody is staying with hypoxia, for acute mountain sickness, we know. Chronic mountain or subacute mountain sickness, hypoxia by itself causes severe PAH with vascular constriction in the medial muscular arteries, and they have severe polycythemia. So I tried to give you some very basics about PH. I do not know whether this is what you needed, but I thought this is a very fundamental core part about PH. We can have some time for discussion. Dr. Subramaniam is there, Dr. Josh is there, Dr. Muralidharan is there. So I'm open to some more questions. Thank you so much.
Dr. Kothari, it was an excellent presentation. You not only covered many of the topics that we needed to from the exam point of view, but also you covered the entire gamut of pulmonary hypertension. Before we go into some of the questions that have come up, I just want to get some clarifications from the exam point of view, namely,
yes, please.
How do you decide on the operability of a congenital heart disease with pulmonary hypertension? I'm sure.
Yeah.
Can you just, for the exams point of view, can you just list them for the students?
So one is clinical, then ECG, X-ray, and cath. So clinically, if you have evidence of a shunt lesion, if evidence of a continuing flow, if you have flow rumble, then the flow is more than 2:1, and the patient should be operable. For example, you have mitral flow murmur or a tricuspid flow murmur in an AST patient, so that patient, and a murmur of VST, murmur of VST, that is easy. Conversely, absence of flow murmur, hypertensive PR murmur. So clinically, that's some part of that we talked about. If your ECG shows sign of continuing left heart overflow, so Q in V5, V6. But see, remember, these ECG are soft signs. We should not go by ECG X-ray findings to decide operability. Whenever in doubt, we need to catheterize. On catheter, what we see, I thought that's a chapter by itself, but very broadly, if your PVRI is less than, an operable range, it's operable. If it is clearly inoperable, then it is clearly inoperable. If it is a middle line range, then we try to do vasodilator testing. Vasodilator testing you do by nitric oxide, by adenosine, by a couple of other things. And what do you see in them? There is a fall in pressure. How much fall we see? There are criteria for Sitbon, fall more than 10 mm of mercury with a mean PA less than 40, without fall in cardiac output, etc., etc. So you have to take a total picture, and it becomes a little complex when you talk of cath, because cath will need a topic by itself. But at the bedside, you should get shunt evidence of a shunt lesion. And you get finding on X-ray. So that's the point I made it. X-ray evidence of a shunt is not a sign of operability. X-ray evidence or ECG evidence of a persistent LVH is not a sign of operability by itself, but everything together could be a sign of operability. But most important thing is an age of the patient. So if you have same amount of mixed data, but age is young, you can still think of operation. So you have to know the natural history of that lesion to take this decision. I'm sure Dr. Subramanian will add on to this topic and point out to some things if I have missed in highlighting from point of view of exam.
Dr. Subramanian or Dr. Raghu?
Thank you, Dr. Kothari. I think I was overwhelmed by the amount of information you have given us. And I think it's going to be useful not only to the exam going pages, to all of us. You have highlighted the varied causes, varied physiological concept behind pulmonary hypertension. And there have been a couple of questions here from the students and also things. Now, before I go to the students' question, would you like to say the differences in criteria for reactivity for IPAH and congenital heart disease? That's one thing students often confuse.
Oh, that's a tough question. Actually, one more point I forgot. Desaturation exercise has been also labeled in a patient of VST and PDA. Desaturation exercise could be taken as a sign of favoring inoperability, but same is not true for ASD. So just keep this in mind also. Now, operability in IPH versus operability in congenital heart lesion. And this is a sophisticated topic, and I think there is some difference. And you know, couple of different people have written it differently. I think operability, now, should they be different? They could be different because pathophysiology is not essential. So some people have written more than 20% fall in PVRI is a sign of, so why are we doing operability testing in IPH? First, we should probably add that. So we are doing IPH operability to decide about therapy, because if there's a lot of for reversibility, we can use calcium blocker. Now, I think this calcium blocker humbug has been overemphasized. Calcium reactivity is seen mostly more in children, and it does not last in half of them. So we should be nearly more secure about it. So I personally think more than 20% fall should be taken for IPH. More than 10 millimeter or 10% is written by Sitbon as a operability thing for PH. But frankly, since I do not believe in them, I do not really remember them, Dr. Sir. I think Dr. Josh, and you can probably add on to this, because this is not something which I remember. These are my thoughts, that I think I would be real more stringent on IPH and would probably need 20% fall rather than 10% fall.
Yeah, according to the literature, I mean, different people have used different criteria for IPAH to indicate reactivity. And some of them use only a mean PA pressure fall of only 10 millimeters with an absolute level of less than 40. Other people use 20% fall in TPR and with fall in TPR with vasodilators, and a 10% rise on withdrawal of the vasodilator. And 20% for another group uses 20% fall in PVR with no change in SVR. Now, the very fact that you got different criteria for different group of authors means probably none of them is perfect. And therefore, now remember, reactivity in IPAH occurs only in 10 to 15% of cases. It's not lesser. And even out of this 10 to 15, it's estimated only about 1/3 to 20% to 30% actually respond to calcium channel block.
Right.
So I agree with Dr. that this test of reactivity and calcium channel blockers is a little blown out of proportion, and in fact, it often puts the patient at risk in doing a number of studies. But having said that, it's still part of the protocol in every guideline you see. Right. So at the moment, yes, it is part of the protocol. Right. Now, something related to that, one of the PGs, Dr. Sandeep, wanted to know, when do you use TPR and when do you use PVR? Right. Total pulmonary resistance or pulmonary vascular resistance?
So PVRI is a better indicator. So whenever you don't have a wedge pressure, or your wedge pressure is not reliable, because see, many of these PH patients, you will don't get a reliable wedge, and practically very often you don't get a reliable wedge. So therefore, you talk of TPR. Ideally, you should get PVRI. If there is a genuine doubt, then no harm in even getting LVED to get PVR instead of relying on indirect measures. But the short answer is that if PVR is not available, you talk of TPR. And conventionally, we talk of the same values, although the values could be different, obviously, once you've taken out the wedge. So we tend to assume that everything is like that. So if the wedge is not available, situation demands you take a LVED. And if it is not possible or it's not desirable, then you can calculate TPR. But in a total clinical context, more often than not, you will not be changing your diagnosis.
Okay. Right.
Dr. Kothari, what about the role of sildenafil in children with pulmonary hypertension? You have been routinely using that or Bosentan?
Yeah. So actually, as you point out, we were the very early ones that used sildenafil because the minute it was available, and since we had nothing else to do, we really tried. So we have been using it very common, and now it has become a standard of care. So there was a scare in between to use sildenafil in children, and some warning were also kept out, and it was from a misreading of a report. So sildenafil in children is very widely used for PAH. For a PPHN in infants, intravenous sildenafil also now is getting available in India also. Inhaled sildenafil, if it is available, or inhaled nitric oxide, is very easily used. So IPH is standard of care, use sildenafil and Bosentan both. Now, there could be another chapter about total IPH management, and I didn't touch upon that for positive time, where we should start with one or two, which one to start first, sildenafil or Bosentan. So when the patient is very sick, my take is like this: if the patient is very sick, we start with both together. The sildenafil is less costly. Patient is not affording, we start with sildenafil first. The response with Bosentan is little more. Excuse me.
One more comment, Dr. Kothari. In the exams, many times the examiners ask, what is the cutoff points for the mild pulmonary hypertension, moderate pulmonary hypertension, severe pulmonary hypertension? You want to comment on that?
So previously we used to say 25 to 29 mild, 30 to 49 moderate, and more than 50 severe, mean pre-pressures. Now since we have changed it to 20, I think it will be reasonable to say 20 to 29 mild, 30 to 49 moderate, and more than 50 severe. And this is a mean PA pressure in adults. Now, let me also clarify that in children, people talk of subsystemic, systemic, but that's also not correct, because beyond 3 months of age, PA pressure in adult and children are not different. So actually the same criteria should be used beyond in infancy in a clinical context. So do you agree with that, Dr. Joss, whether you will agree with this 20, 29, 30, 49, and 50? And wedge pressure, people have not changed. Wedge, we still say 15, above 15 to 19 mild PVH, 19 to 24 moderate, and above 25 severe PVH. So this should be the hemodynamic definitions.
Dr. Murali?
Yeah. Yes, sir. Sir, excellent talk, sir. First of all, we had a it's a great learning experience the last 1 to 1.5 hours. I have 2 points I want your comments. One is the role of anticoagulation in non-thromboembolic pulmonary hypertension. We have been traditionally giving anticoagulation as one of the mainstay of therapy. Where do we stay there? Because the positive evidence, or what is it? Number one. Number two is, many of our friends, transplant teams, when they check for the PVRI, reversibility to decide on heart for the heart lung, they catheterize the patient, watch them the intensive care unit for a period of 24 to 48 hours, challenge them with various vasodilators, and keep checking the thing rather than 1 point measurement. So we have been routinely doing in the cath lab just the reversibility, which is right. They have got longer time. They say that's a better method rather than 1 point estimation. Wait for 48 hours to measure, particularly when they want to do an organ transplant. I want to draw your comments on this too.
And what do they do for 48 hours?
They change their vasodilator. Pulmonary vasodilator, they use different things, from calcium blocker to even phosphodiesterase inhibitors. They keep checking the PVRI or transpulmonary both in different types. They keep the catheter in like a swan gun, continuously measure to look for reversibility rather than designing on at 1 point estimation.
I see. So 2 questions. Thank you, Dr. Murali. So these are very interesting questions. You see, anticoagulation is a real bother for IPH patients. See, the trouble is, I have, and you must have seen, patient had hemoptysis once 4 years back, and then later on there was no hemoptysis, and then suddenly next month there is a massive hemoptysis. So when you use anticoagulation, so what data we have? We know for sure from trial that PSS patient prognosis is worse with anticoagulation. Majority of IPH group in subgroup analysis do not show much benefit with anticoagulation. Our worry is that since we do not have heart lung transplant very severe, can we really retard progression? Because autopsy do show thrombi in them. So how do we go around this? So I have been asking this question to many people who have seen even more than what we see, and the answers are not really. So it is a case by case basis. If you suspect that there is no hemoptysis and the patient is younger and might not have developed severe thrombi in the thing, you can take help from CT, whether peripheral in situ thrombi are there. If something is there, I will are on the side and give a small dose, keeping INR not more than 2. Whether this is right or wrong is very difficult. But if CT EPS there's no question, then we really will do them. So in a case by case basis, with a low threshold of INR and not in majority of the patient. Somebody who has had hemoptysis history, I do not think we will favorably influence the course, but it's difficult to be sure. So the real answer is that it is not really very well known. Personal bias is like this, that you see a patient who has no chance of any big therapy, nothing else is on the card, and no history of hemoptysis. I would tend to give a low INR anticoagulation. And the other thing is very interesting in heart transplant. See, the transplant stakes are very high, and so they want to be really very sure. And when I was talking of PVRI, one should recognize this, that PVRI 5 looks normal, innocuous, but a PVRI 5 is a contraindication to lung transplant, heart transplant, and the heart acutely is not able to handle any more thing. So they really want to be very, very sure. So I think it is the stake which is pushing them to do so. I do not know whether, so what you would like to know? You would like to know that you have maximally vasodilated them. So when we do spot test in PVR once, we may not have been achieving that particular thing. So since the stakes are high, they want to do it at 24 hours and keep the thing going. Because see, if you see prostacyclin data, the fall in PVRI is gradual. It does fall over time. So there could be some sense in there doing it then, but the argument could be why 24 hours, why not see it for 48 hours, etc. But I think it's a reasonably good idea. So if you are having a borderline situation, if your answers are not very clear and you still don't have, because organs are very limited, so they maximally vasodilate and see what happens. It's like probably giving adenosine for coronary vasodilatation longer. So whether it asymptote, whether the curve flattens out, I would only guess from prostacyclin data that PVRI keeps falling. So I think I will be with them that if you are a borderline, no harm in, and if you are not hurting the patient by keeping catheters in 24 hours, it's good to see if you are really in borderline situation. Morally, that's a great question.
But that puts me another interesting thought. We were part of the treprostinil trial where we had a indwelling catheter in the right heart, subcutaneous catheter, and using a pump to give continuous prostanoid infusion.
Right.
What we noticed was the pulmonary artery pressure remained same. But when the PVRI we calculated, it was falling down because the cardiac output was started improving.
Right.
So by echocardiogram, even when you put a cath, the PA, but as you rightly said initially, the pulse pressure becomes wider. Systolic pressure remained high. Casual TR examination was disheartening, but when you did a PVRI, it was very good, sir. What do you think about it?
So this is also written up that on prosta, the cardiac output keeps on rising over time, and therefore the doses needed also keeps on going up. So basically, nothing much is happening to the lungs, actually, isn't it? Rather, more cardiac output, more flow is giving that artifactually fall in PVR. Now, whether we are doing good to the patient, so I have not really had this experience of using prostacyclin at all. Rather, you could probably tell me that was the patient feeling better as the calculations were showing? Was there a symptomatic improvement?
Yeah, it was a part of the freedom trial that was conducted some 5-6 years back. I think that Taniyacharan sir will be in, he can talk on it. But what happened, the clinically patient improved. Patient had an excellent clinical improvement. Their effort on improved. Their cardiac output improved. PA systolic pressure remained high, but when we calculate PVRI, because the QP has improved, the PVRI came down. That's what we noted in that group. Actually,
if even a few millimeter fall in PA pressure makes a lot of clinical improvement. And so therefore it is more than PA, also something else is also happening. And we know prostacyclins are anti-proliferative, change compliance, increase the flow. So I think all in all, we are happy if the calculated PVRI falls. We should be happy. And even though we don't understand it fully, we would appreciate that we are on the right lines.
Yes, sir. Rahul, sir.
Yeah. Two students would like to ask a question on your, you already talked about ASD and mitral valve disease and operability. Yeah. But their question is, clinically, how do you decide which is contributing to pulmonary hypertension? Is the ASD or the mitral stenosis?
Okay. So clinically, see, severe mitral stenosis will give you more flow. So whenever you have more flow, so it is not a ASD Eisenmenger. You could not get a patient of ASD MS who is Eisenmenger. That means ASD MS patient will not get Eisenmenger because unless the MS has developed after he become Eisenmenger from ASD, which doesn't happen. Because for MS, flow has to be high. And if the flow is high, the PVRI will come down. So patient of ASD MS will die from heart failure and not from PAH. Now, which is higher is an artificial question, because unless you say ASD was moderate and it is restrictive. So if you have restrictive ASD, have a continuous murmur, then you know MS is the problem. Otherwise, MS and ASD both are causing the same problem. Both are pushing the flow in the lungs, increasing PA pressure, but simultaneously giving us an assurance that it is always operable. So ASD, MS, gluten pressure is always operable. And the severity of MS would determine. So what you can do is you can calculate PVRI, we can calculate QP, and we can calculate severity of MS. So there could be a patient who is having only mild MS, for example, and has a large flow ASD because he's a large flow ASD. So in that patient, ASD is more, and another patient with severe MS, the flow is largely driven by MS. So you could have both patients, but both will be operable. Does that answer it?
Yes, thank you. And I found your explanation of that one lung hypertensive, IR is equal to IR 1 plus 1 upon IR2. I found it very fascinating. In fact, we find that in idiopathic PAH, even if you replace one lung, the resistance comes down, the patient often improves.
Yeah.
But one of the students has asked a question related to that. When you have hemitruncus and one artery is sort of connected to aorta, so there's something called crosstalk. And we were hypertensive, become hypertensive. Is there crosstalk or not? That is the question she is asking.
Yeah, wonderful question. So your voice got cut in between little. So practically question is there a crosstalk in hemitruncus or not, right?
Yes.
So see, in that particular patient that I showed, the right lung was protected. So right lung was having low pressure. So there is some crosstalk of which we do not understand much. For example, you have one pulmonary vein obstruction. Dr. Subramanian will remember Dr. Tandon always used to say, one pulmonary vein obstruction can give you severe PAH, both the lungs. So there is certainly a crosstalk, but the nature of that crosstalk we do not understand very well. For example, you have a pulmonary embolus in one lung, and a pulmonary embolus in one lung is giving you histopathological changes in the other lung also. Now people have appreciated that also. So there is, for sure, there is a crosstalk, but you are asking a beautiful question, and the answer of that crosstalk is not very well understood. We practically take that if one lung is protected, is histopathologically also probably protected, then we are okay in terms of management. But if you have a hemitruncus who is now say 10-year-old and has that RPA from PA, that lung would also be isomangarized. How would that influence the other lung? Whether there are any biomarkers, whether there are any chemical which flow and cause PAH, we don't know. We know from liver disease, etc., that there are some chemical which influence PAH also. So I'm sure, great question. There must be crosstalk. What do you think, Dr. Subramanian?
Well, I'm entirely with you. I was hoping you will give me the answer. I don't know. Yes, there is crosstalk, but we don't understand it fully. We often see this, and very often, you surprisingly, even adolescents with pulmonary artery coming from the aorta, you correct it, and the pressure comes back to normal. Right. So I think yes, I agree with you. It's a poorly understood area.
Some of that relevant answer could be that some of the SRIHER patient there are studies showing from the blood, that from the blood can you guess what is happening in the lungs? You know, not of late 3-4 years ago, from circulation there is a paper saying that by the look of the blood picture you can say what is happening in the lung, which is indirectly telling that the body is in whole. It is not only isolated lung there. So someday we will know some biomarkers which can tell us about the reversibility and what is happening in the circulation. Great.
Dr. Murali?
Yes, sir.
Any comments?
Pritam, any more questions from the audience, delegates?
There are a few questions, sir, which of course is more towards the management.
Yeah.
Like VST with PDA, having a borderline PVRA. Can we give sildenafil for a year and then again repeat cath and plan for operability?
Yeah, the great question. I don't think these people who are asking this question needed this lecture. They already know whatever I talk. So this is an important question. We have recently written a review article on treat and repair. See, this is oversold again. Treat and repair may be reasonable if your PVRI is not very bad. See, there is no harm in giving but in post-capillary PH, in patient of VST and PDA, I do not think the natural history will be totally changed by giving vasodilator for a year or so. So suppose you are having a very borderline situation. That means you have only PVRI of 6 and your child is about 7 years and you want to be doubly sure. You want to see what happens. Nobody knows the answer because by 6 months of sildenafil and bosentan, suppose you increase the pulmonary flow, could that damage it already? You restudy after 3 months. I would think it is reasonable if you are in doubt to restudy quickly, maybe 3-4 months. If there is a very good change in PVR, maybe happily send for surgery if you are so inclined. Doubtful, you don't send for surgery. Whatever data and literature I have reviewed it and written a review article, you can read that for details. Treat and repair in pulmonary circulation. We scanned the entire literature and came up with this, that if the PVRI is less than 11, we can try this strategy. If the PVRI is more than 11, then all the reports which say that reversibility could matter is humbug. It is overdone. And if you are in doubt or the PVR is very high, you should probably think that it is not going to change. Well, in an individual case, you give and see what happens. If you are lucky that PVRI dropped below 6, a relatively younger patient, you should do that. Trouble is you will commit them for a Eisenmenger type of physiology and commit them for lifelong vasodilators. We do not know whether we will be able to stop them. So you should be more careful in embarking upon this strategy. I can just caution you, but case by case, one has to see.
Can I add to that?
Yeah, please.
I want to make a comment on that. Yes, I am absolutely in agreement with Dr. Kothari. I don't really believe that a truly established Eisenmenger, you can reverse it by vasodilators and enough. Well, you can reduce the PVR, but you will reduce it enough to make him operable, which is, I think, not a reasonable statement.
Right.
However, there are some clinical situations where a reversible factor, if you remove it from the clinical scenario, the patient may become operable. Now, one of them is mitral stenosis. Just Dr. Kothari mentioned that. If you remove an obstructive lesion in the circulation, the apparent inoperable status of PAH actually becomes operable. The other situations, one of them is Dr. Ilayaraja has highlighted in his question, extreme obesity. Extreme obesity, looking cyanosed and looking inoperable ASD. When you remove the obesity and remove the hypoventilation situation, the hemodynamic may look operable. Therefore, one of the conditions for discussing operability and inoperability is all reversible factors have to be removed. That's one of the conditions before you talk of inoperable and operable PVR. Anything that is reversible, like chest infection, like hypoxia, hypoventilation, all the reversible factors which assume that you have removed, either acutely or on a more long-term basis. That's one of the conditions to talk about inoperability. Thank you.
Right. We had a patient with adenoids, severe adenoid, and then PA pressure, and also thromboembolic fellow. When we removed the clot, the PA pressure really fell down also. So even that CTEPH is also one of the reversible things.
One student has asked, how do you interpret total pulmonary gradient and diastolic transpulmonary gradient and diastolic pulmonary gradient in univentricular heart? Yeah, for the students' information.
So see, it is very simple to understand that diastolic pulmonary gradient is much better than total pulmonary gradient. And TPG, because TPG includes systolic pressure also, because you take mean minus wedge. So it will have systolic also. So they say it will be influenced by stroke volume also. So that means non-vascular factor. We are interested in seeing the lung only. So for single ventricle, this assessment is even more difficult. So what your mind should be there will be at what is the difference between PA diastolic and PA wedge. And probably the background information could be that normally it is only 1 to 2. So even if a diastolic gradient is more than 7-8 millimeter, and in single ventricle physiology, the difficulty is because the QP is quite low and it's not pulsatile. So whether the same criteria should be there. So all in all, your assessment of PVRI would be your threshold for thinking of PVR will be very high. And should you find anything beyond 7, you will start them on vasodilators. But we will not like to think of TPG there. We'll really like to think of DPG only. Because there is hardly anything which TPG adds in our understanding over DPG. Converse is true rather. It misleads many times because there is a systolic pressure also. Now there is no pulsatility, so PA systolic is not very much there. So probably the questioner wants to say that they are nearly same there. Now, in the absence of pulsatility, could they two be considered as same because there is no waveform? So that's an interesting thought. I really didn't think of that. Now it seems to me that probably there should be no much difference between the two. But instead of taking a mean line, mean PA pressure, we could still take what looks like at diastole.
Thank you.
Dr. Murali?
Sir. There are no more questions.
Sir, Kothari, sir, thank you, sir. It has been a pleasure to hear your wisdom. Actually, whenever I used to read Perloff, I used to feel that every time I get new information. Similarly, whenever I hear a lecture, I mean, every time I'm getting new information. I think this is going to be in YouTube, and I wish all the students can go through at least 100 times, because the information that has been given cannot be taken in one class itself. It has to be repeatedly heard. Sir has given whatever knowledge he has acquired over a period of 3.5 decades of his practice of cardiology. Thank you, sir. Thanks a lot for accepting our invitation to be a speaker in this forum and educating all our students.
Thank you,
Thank you, Dr.
Bhupati.
Raghavan.
It was such a pleasure to be with Dr. Josh and Dr. Subramaniam, and with all of you. My pleasure entirely. Thank you so much.
Thank you very much, sir. It's a great pleasure. Great evening, sir. Thank you all. Thank you, Joe, sir. Thank you, Raghavan, sir.
Thank you, sir.
Thanks, Bhupati,
Thank you.
for bringing the Kothari sir amidst us. Thank you.
Thank you, everybody.
Thank you all. Yes, Kothari, once again.
Thank you, sir.
Postgraduate students, we will be having a virtual case presentation on Tuesday, which will be moderated by Dr. Taniyachalam, who is our chairman, and Dr. K.K. Talwar, who was one of the professors of All India Institute of Medical Sciences, who became a director of PGMH here. It will be on Tuesday. I'm trying to share the screen, Preetham. Okay, it will be on Tuesday. We will be sending the links to you so that you can see it.
Thank you.
Thank you, everyone, sir. Again, Kothari sir, thanks a lot, sir. We were overwhelmed, sir. The amount of knowledge what we got was tremendous. Thank you, sir. Thank you.
Thank you.
I was back in morning session, sir. Thank you, sir.
Bye. Great. Thank you, Bhupati. Thank you.
Exactly, sir.
Bye.
So same 8 o'clock experience.
Thank you.
Thank you, Dr. Murali, Dr. Bhupati, and of course, Dr. Jacob Jose.
Thank you.
Fantastic, man. And of course, Kothari, no words.
Thank you so much. Bye.
Thank you. Stay safe, sir. Good day, sir.
Thank you, sir.
Okay, bye. Good night, everybody.